So on the last slide, I told you that you should consider IPF if you see reduced lung volumes. And in general, interstitial lung diseases do produce reduction in lung volumes. But there are a few that have preserved or even increased lung volumes. And this is a list of those. LAM, tuberous sclerosis, which causes a form of LAM. Sarcoidosis, pulmonary Langerhans cell histiocytosis. Chronic hypersensitivity pneumonitis. Silicosis, and of course, as we talked about earlier, interstitial lung disease superimposed upon COPD. That's a list that sometimes comes in handy when you see a patient with interstitial changes and their lung volumes actually look relatively normal. I also like to when I look at x-rays or CT scans, determine what the predominant location of the findings is. Is this upper lobe? Is this diffuse? Is this lower lobe? Interstitial lung diseases with an upper lobe predominance are sarcoidosis, rheumatoid lung, ankylosing spondylitis, chronic hypersensitivity, silicosis, Langerhans cell histiocytosis, and LAM, although LAM actually usually is more diffuse. And lung disease in general with an upper lobe predominance, again, I like mnemonics, and I think Wes Ely is responsible for this one. But diseases with an upper lobe predominance, sarcoidosis, TB and fungal infections, aspergillus infection, rheumatoid lung, cystic fibrosis, chronic HP. Some of these I've repeated. But things to think about when you see diseases involving different areas of the lung. Lower lobe predominance for interstitial disease, IPF, we talked about predominance in the lower lobes and in the subpleural areas. Asbestosis, dermatomyositis and polymyositis associated interstitial lung disease, of which I have 2 or 3 patients with. Lupus and scleroderma. Okay. So I promised that we would talk about high-resolution CT scan of the chest. So let's do that a little bit. Again, this is essentially the standard for imaging of interstitial lung diseases. The way it's done is use of a thin collimation axial or thin section reconstruction of volumetric data obtained by the CT scanner. And that's obtained with a multi-detector CT scan optimally. Most CT scans now, there's very few single-detector CT scans still in operation. I'm not sure if there are any. But they're now up to 64 and 128 slices. So this is pretty easy to do on most modern CT scanners. These sections are very thin, usually between 0.5 and 1.5 millimeters, and that's just to contrast, a standard CT scan is between 3 and 5 millimeters. They use a high spatial frequency data reconstruction algorithm, and the radiologists and the people who develop these algorithms try to balance the use of sufficient radiation to decrease noise while limiting the radiation exposure to the patient. And these are the technical settings used. The acquisition is using an ECG-gated or segmented reconstruction, and that limits motion artifact. The heart beating can actually cause motion artifact and can blur your image. So there's a lot of gating and other techniques used to limit motion and noise. Generally, the scans can be done inspiratory or expiratory, and if you do expiratory scans, they generally use triggering of when the expiration takes place. The standard is supine full inspiration scanning, but you should generally do prone imaging in patients with suspected interstitial disease or those with dependent abnormalities on supine imaging, and I'll show you some examples of that in a minute. Expiratory scanning can be very useful in patients with obstructive lung diseases or obstructive interstitial diseases, including COPD, asthma, bronchiolitis obliterans, constrictive bronchiolitis, and a whole host of other changes, including hypersensitivity pneumonitis. So this is, I hope you can see, this is actually the same patient, the same scan on the same day, and on the left is a high-resolution image, and on the right is a standard 5 millimeter CT image. And I don't know how well this projects, but at the same anatomic level, you can really see a lot more detail on the high-resolution scan than you can on the standard 5 millimeter cut. You can actually start, this is a patient with IPF, by the way. You can see the subpleural predominant linear opacities. You can see some areas of traction bronchiectasis and honeycombing. And here, you know that there's something wrong at the base of the lung, and you're kind of getting an idea for what that is, but you can't really tell specifics. And you can really see honeycombing here at the left base. So I think this is a slide that really shows you the difference between standard CT scan and high resolution. So I'm going to go through really quickly the high-resolution CT scan findings in patients with idiopathic pulmonary fibrosis. And what I've done is I've actually, this is a reproduction of a table from a paper by Ryu from Mayo Clinic Proceedings that was actually quite enlightening about interstitial lung disease. So typically in IPF, chronically, if you have a chronic reticular pattern, that can be seen in IPF. Cystic air spaces, if it's chronic, that can suggest honeycombing, and you can see that in IPF. The distribution is, of course, as we talked about, lower lobe and subpleural or peripheral predominance is seen in IPF. It's also seen in other diseases as well, but particularly in IPF. And you can see traction bronchiectasis, of course, in IPF as well. So this is another slide I got from the pilot deck that shows you the expected findings for IPF. Irregular reticular abnormalities, subpleural, posterior, lower lobe predominance, subpleural honeycombing, minimal ground glass opacities, traction bronchiectasis, especially later in the disease, and you usually have mild lymph node enlargement, not large, bulky lymphadenopathy. When should you consider alternative diagnoses? Patients who have a pleural effusion, pleural thickening, patients who have ground glass opacities that are more than minimal, large mediastinal or hilar nodes, and central lobular nodules and cysts. So other findings, you should consider an alternative diagnosis to IPF. Prone scans, by the way, are often best for showing early abnormalities, and I'll show you a slide here in a minute. This is a slide that I shamelessly took from Dr. Noth, and it shows some of the changes that you see in IPF. This is traction bronchiectasis, and what that means is bronchiectasis is dilation of the bronchi. In IPF, you get scarring of the surrounding lung parenchyma, and actually this tends to pull on those bronchi and enlarges them, and that's why it's called traction bronchiectasis. You see diffuse honeycombing and interstitial alveolitis, and the honeycombing is predominantly basilar and subpleural. At the bases, again, bibasilar honeycombing can also be seen. This is a prone CT scan that shows some of the early findings you can see of reticular changes on prone high-resolution CT. So that can be very, very useful in seeing early changes. This is an interesting patient, and I don't know how well this projects. This is a patient who is 67 years old. He carries a diagnosis of CREST syndrome for about 10 or 15 years. He was sent to me because he was having some respiratory complaints, and I did end up doing a high-resolution CT scan of the chest on him. And when I first looked at it, I said, he's got some changes. You can actually see some mosaic ground glass attenuation here in the lower lobes. But when I looked at his prone CT scan, high resolution, it's clear. So I felt a lot better after that. Sometimes prone things that are seen in the supine CT, especially dependent changes, will go away when you prone a patient. So that's why I like to prone most of the patients I'm evaluating for interstitial lung disease.